Good morning. This is Babak, Larian. Hope you are all well. This is another session of Facebook Live question and answer session on primary hyperparathyroidism. So today I'm actually going to start by discussing a case that you may find interesting because I actually found it immensely interesting. I'm going to go ahead and switch to that case. It does show some surgical pictures, so if you are a little, shy about looking at surgical stuff, this may not be a good start for you, but here we go. So this is I'll let the surgery run and then I'll explain everything later. So this is a person who is a young woman, lives in another country, had 3 previous surgeries. She had the first 2 surgeries in another country, and then the 3rd surgery was by me. So let me explain. So she had, first surgery she had, they had scans done. They thought there was something that they saw on the neck. They proceeded to do a standard parathyroid surgery, minimally invasive with a small incision in the lower neck. And they looked at both sides of the neck. Were able to find one parathyroid on the right side superiorly, which appeared normal to them, and another parathyroid on the left side, which they removed, and the PTH didn't come down. They did an extensive exploration, couldn't find other parathyroids, PTH didn't come down, and they closed up. The patient was paralyzed now on the left side of the left vocal cord. Continued to have a lot of symptoms, affected her deeply. They proceeded to doing another scan, a 4D CT scan, which showed a lesion on the right upper neck, just under the jaw. And so they underwent a second procedure where this lesion was removed. It was next to the carotid. It was removed and found to be a lymph node. So obviously there was no decrease in PTH and the patient didn't get better. So at that point she came to me and we did extensive scanning with very little in terms of finding. So she opted to undergo a comprehensive exploration of her neck. So I opened the same incision. I was using the breathing tube. We had made a deal with each other that since her vocal cord was paralyzed on the right side, on the left side, she had a paralyzed vocal cord, that we wouldn't go to the right side in the area where the nerve existed in the lower neck, just so we would not risk any potential injury to her nerve, which was a very reasonable and sensible discussion that we had, and we made that deal together because although you can tolerate a one-sided vocal cord paralysis, and that's correctable and you can get the voice back to a normal speaking voice, not singing voice, bilateral vocal cord paralysis is devastating, and that person would need to have a breathing tube in her neck. So that's not something I wanted to risk, and obviously she didn't want to risk either. And so I proceeded to do an exploration on the left side, right? And I'm going to flip you around and show you. So we did an exploration on the left side of her neck, right? So she had a paralyzed vocal cord on this side. So I went on this side and basically, let me draw it in color that's visible. I basically cleared up everything, this area and this area, and then I went up. Now the vocal cord comes down like this, turns around, and then goes behind the thyroid to get to the voice box, right? So above the level of the vocal cord entering, I also went and explored. And I was not successful. I didn't find an enlarged parathyroid. So she went back to her home country. And we did further scanning. The labs were still inappropriate and she was not feeling good. So we did further scanning, and she was able to do a PET choline scan. And on the PET choline scan, she was able to find, let's see, a lesion. She was able to find the same lesion that the second surgery was supposed to take out was here. So if you were to imagine that this is the jawbone, and this is the joint of the jawbone, right, with teeth in it, okay? The tumor that they found on the PET choline scan was somewhere deep to the jaw up here, maybe even a little bit further up, right? And so you have to imagine that this tumor is deep to the jawbone, right? So flip this around, the tumor was underneath the jawbone, this far up on the inside. So the place is called the parapharyngeal space. Pharynx is the throat, parapharyngeal space is the space between the throat and the jawbone, in a sense, right? So let me take you back. So we saw that on the scan. The second surgery had not been successful in finding it, right? Because they had not gone far up enough to see it. So I got the 4D CT scan and superimposed it on the PET CT. I could see exactly what it is. It was at the deep point of this thing, immediately adjacent to the parotid salivary gland, the deep portion of it, deep to the jaw. And so this is the surgery. I'm gonna go back here. So just to explain, this is surgery video. This is the person's neck, front of the neck, back of the neck. This is their jawbone and chin here. Lips would be up there. This is the earlobe, you see. Okay, the incision is underneath the jawbone here. This is the incision. And here we go. You'll see the carotid artery here pulsating. This is the jugular vein. This is the nerve that goes to the tongue up there, and this is the parathyroid adenoma. And you can see the pulsations here of the carotid artery. So basically tracked and got it there. Now, the next video, I'm going to show it again. Carotid artery is here. Jugular vein, the vein that comes back from the brain there. The nerve to the tongue is this whitish structure, and this is the tumor, the parathyroid adenoma. This is after the tumor was removed. So you can see here, there's no tumor anymore. You can see the whole nerve, which is still intact. The tumor was in the sheath that covers the nerve. So in this picture, you can see a capsule on the nerve, and in this picture, there's no more capsule because the tumor was in the capsule, so I had to open the capsule to get the nerve out. And this is the carotid artery, again, and the vein. Okay? So, and then during the surgery, the PTH came down, everything got better, and she's feeling significantly better. The caveat to all this is that she actually woke up with a weak tongue, which took about a week to fully come back to normal movement, and she was back to normal. As luck would have it, our tongue is incredible because if half of our tongue gets paralyzed, this is one of those unbelievable things, the other half of the tongue, which has its own nerve from the other side, is capable enough to move the tongue well enough that you can speak normally and swallow normally. You know, the first day or two, she had a lisp, and then it recovered. But in any case, after a week or so or two, the nerve was fully functional, and she was fully back to normal, and she feels well, and calciums are down, PTH is down, everything's normal. So this is just to demonstrate how crazy parathyroid can be, where they can hide, how unusual it can be, and how you can get into trouble as a parathyroid surgeon if you're not paying enough attention to the individual, all right? And that can be obviously a huge problem. In any case, I'm gonna start by answering questions now. So we'll start with the first question by Lisa Conrad Johnson. My primary care physician says my parathyroid cannot be causing my kidney stones and osteopenia because my calcium blood levels are in range. What range would be acceptable for a 57-year-old female displaying the above symptoms plus frequent urination, insomnia, jaw and teeth pain, hair loss, high 25 urine calcium, and fatigue? Lisa, I'm gonna go flip you around to show you my favorite slide. And my favorite slide is this. This was the slide. This is what I found that was eye-opening to me as it relates to parathyroids. So here we go. On the surface of each parathyroid gland is a sensor for calcium. It's called the calcium sensing receptor. When enough calcium's attached to it, it shuts the gland down and it stops it from producing PTH. Okay? And when there's not enough calcium, it produces PTH. So the relationship between calcium and PTH is this curve, this inverse curve that comes down, and that inflection point there is called the calcium set point. That set point is genetically predetermined. So you are born with that set point. Your parathyroid glands, this receptor is designed for, let's say in this individual, 9.5. At the age of 1, they'll try to get a calcium of 9.5. At the age of 95, they'll try to get a calcium of 9.5. There is no age-specific calcium level in the blood. Your sensors for calcium are genetically made. They are your numbers. They will always be your numbers. Those numbers will not change from the age of 1 to the time you die. Your body tries to keep your calcium at that level. You have that same sensor in your kidney, in the bones, all around, right? And that sensor doesn't change its genetic shape as you age, right? That's a gene that makes a protein, and that gene is what it is, and it doesn't change. That gene doesn't change. It's the number of proteins that are in the receptor, right? And the number of amino acids that make the protein that's the receptor. So this whole idea with calcium being different at different ages is a fallacy. It ignores the absolute fact that you're designed with a sensor and your body always wants the same calcium level. And as soon as your calcium level changes minimally, it goes from 9.5, in this individual, if it goes from 9.5 to 9.4, you have a 30% increase in PTH. You go from the 50 percentile to 80 percentile, right? And by the same token, if your calcium goes from 9.5 to 9.6, you have a 30% decrease in PTH, right? So your body's excitingly and absolutely and amazingly precise about how it deals with the calcium. It doesn't want too much alteration. So yes, although you follow this curve, and sometimes you'll have, with your set point being 9.5, you'll have a calcium of 10.2. Let's say you drink a large glass of milk with vitamin D, and have had salmon that day, you have loaded up with vitamin D, your body's ready to absorb all the calcium it can, your calcium quickly comes up, your PTH drops, and then calcium goes back down because the calcium gets absorbed into tissue, into bones, or gets filtered out by your kidney. And then if your calcium sometimes goes down really low, right? You've done stuff to filter it out, you've drank a lot of water, you're exercising hard, and your bones are absorbing calcium to try to build bones, stronger bones, something to that effect. And that causes it to come down, and then immediately parathyroid production goes up, PTH goes up, and brings your calcium back to this level, okay? So you have very precise control over your calcium. It is not age dependent at all. Now, what I would say is that if your calcium is in the normal range, that in and of itself does not tell you if you have hyperparathyroidism, because you can have what we call normal calcemic hyperparathyroidism. This person who's suffering from low impact wrist fracture, depression, constipation, and aches has a calcium that's in the normal range, right? But his PTH was elevated. The only reason this person found this issue is because they had a fracture, and it didn't make sense for them to get a fracture at the age of 48 with such a small impact. So they did a bone density study, and they found that this person had osteoporosis. Part of the workup of osteoporosis is to check PTH, and then once they checked the PTH, they found that it was elevated. Then they discovered that this person has a normal calcemic hyperparathyroidism, and so on and so forth. So, Lisa, without knowing what your calcium, PTH, vitamin Ds are, it's hard for me to tell you, all right? Now, there are people who have osteopenia, especially postmenopausal women, can have osteopenia at the age of 57, right? There are people who inherently make kidney stones. Not every person who has kidney stones has hyperparathyroidism. Not even a majority don't. But having osteopenia, feeling the way you do, and having high calcium in your urine and kidney stones warrants more of an investigation. So you should really look into it and get calcium, PTH, vitamin D, the 25-hydroxy vitamin D, right? The 25-hydroxy vitamin D. I also urge you to get 125-dihydroxy vitamin D, right? And look at these numbers. I would do it fasting at 8 o'clock in the morning so that nothing is affecting the PTH production, so you don't get a false elevation or a false decline. And that way, and I would do it on multiple occasions. I would do it more than once. I would do it 2 or 3 times, even 1 week apart, as long as it's done fasting at 8 o'clock in the morning, and make sure you're not taking any biotin when you're taking this for at least 2 weeks prior to doing the blood test. That way you don't have anything interfering with the results, and that way you can tell, hey, look, yes, true, my calcium is normal both times, but my PTH is inappropriately elevated both times, and my vitamin D is normal. If it's not normal and it's low, I'm sure your doctor will give you vitamin D replacement and then repeat the labs. Marijo Gibney Hutchtoll, I'm sure I insulted your name, but is asking, normal hormonal hyperparathyroidism is vice versa. Correct, yes. Normal hormonal is when you have calciums that are elevated, right? But PTH that's in the normal range, right? All of these are same diseases, by the way. This is nomenclature. This is the way we categorize things, right? It's just harder to get to a treatment point for patients who have these abnormal presentations, because it's hard to understand these diseases. Most doctors are not aware of them even, unfortunately. GD RAS, my malfunctioning parathyroid can't be seen on any scans or imaging. Is it possible that it can be removed? So GD, first I would have to say, what scans have you done, right? Because the standard, I'd say more than 90% of the universe, when they are diagnosed with hyperparathyroidism, they get a sesame scan. Some get ultrasound, not all, unfortunately, right? And I would say that the sesame scan is probably, of the scans that we have for hyperparathyroidism, the least reliable one, right? And so if you've had an ultrasound and a system EV scan that's negative, that doesn't tell me much. All right, and let me try to explain. I'll flip you around again. So let me bring up the scans. All right. So the four main scans that are somewhat available. Ultrasound is the first scan that should be done on each patient with hyperparathyroidism, preferably by someone who's interested in parathyroid disease, preferably with someone who's had some experience. The reason for it is that it can show it, as you can see here, clearly can show a parathyroid, and it can show its relationship with respect to the thyroid, the muscles of the neck, skin. You can tell how far away the parathyroid is from the skin and where it is with respect to the thyroid, blood vessels, and so on, right? It has no radiation exposure. It's just all sound waves. There's no harm. There's no injection, nothing. If that is negative, I usually go to a 4D CT scan as the next step, right? And try to see if I can find it on a 4D CT scan. It is rare for me to use an system EV scan. The system EV scans are only 85% accurate. Let me see if I have the study to show you. There you go. It's only 84% accurate when your PTH is over 150, right? And it's about 54% accurate when your PTH is less than 100. So what does this all mean? The system EV scan is a scan of system EV scan is a tracer that has a negative charge on it. It gets attracted to the positive charge of the mitochondria, which is the engine of the cell. So a parathyroid cell that's working hard, its engine is working hard. The engine gets more of a positive charge. The system EV gets attracted to that positive charge because it has a negative charge, blah, 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 so on and so forth, right? This scan is not specific for parathyroid, it's specific for function. So that's why we have a system EV heart scan to see which parts of the heart are working hard and using up energy and which parts are not, which is why you see the activity in the heart of this person here, right? You also see activity in the salivary glands because they're constantly producing saliva, right? So and you can see some degree of activity in the thyroid gland right there. And this is the parathyroid, it's down here, right? So not so specific as a scan, unfortunately. I wish it was. And so I rarely use it. I probably do a system EV scan maybe 2 or 3 times a year. It all depends on what you mean by can't be seen on any scans. If you've done a system EV and an ultrasound hasn't been seen, you still have a 4D CT scan and potentially a PET choline based on availability. So I would do those. Now, if all the scans you've done are negative, right, then you have to consider that you may have parathyroid hyperplasia, which means all 4 of your parathyroid glands are abnormal and problematic. And so that may be something that you have, and that may be the surgery that you need is to go in there, explore both sides, find all 4 parathyroids, try to see which one looks the most abnormal. If there's one or all 4 look abnormal, then you address it accordingly, okay? Best of luck, GD. Frank Adelson. Hello, Dr. Larian. Thank you very much for offering these opportunities for everyone. You're welcome, Frank. It's my pleasure. I was wondering what your experience has been with people who took lithium for years and developed primary hyperparathyroidism. Have they tended to have single adenomas or hyperplasia in your experience? Most have had hyperplasia, but I still have seen people with adenomas as well. So although most have hyperplasia, you can still develop an adenoma and have a single gland or two gland adenoma. So it's definitely worth doing the scans and trying to see if there is one or two glands that are larger and different, and looking at those first during surgery to try to be as minimalistic as possible. Next question is, anything someone with lithium-caused hyperparathyroidism should do differently to ensure full recovery after surgery? Not necessarily. There's nothing in particularly different for patients who have used lithium, except that the chance of hyperplasia is higher. I would say trying to get the vitamin D to a good level is a good help, because vitamin D being normal, magnesium being normal, helps the recovery period, right? Now, sometimes it's impossible to get the vitamin D normal, right? And so if you're taking massive doses of vitamin D and you're not normalizing it, I wouldn't push that so much. It's just your body trying to do anything it can to bring the calcium down. But I would say do the normal things. Exercise, eat well, sleep a lot before surgery, and get your body in tip-top shape, and optimize your calcium and magnesium and vitamin D and magnesium, and that's pretty much all you can do. Best of luck, Frank. One more important thing, find an experienced surgeon, someone who does parathyroid surgery a lot. A lot means a minimum of 50 a year, okay? And make sure that they talk to you about how they deal with hyperplasia. Ask them if they re-implant one of the glands or if they leave it in place and mark it. I prefer to leave it in place and mark the fourth gland, so I know where it is. I confirm that it was the parathyroid that I saw, that I know that the blood vessels are feeding it, and make sure they're doing PTH testing during surgery, because that way you know the fourth gland that you've left behind, or left a portion of the gland, is functioning adequately enough for you to be okay. Okay? So that's what I would do. Donna Shepard, is it on this page or a website? I'm looking for a link. Donna, I hope you're here. Pauline Coran. Hello, Dr. Larian. My daughter has suffered psychotic episodes and no appetite, among other things, in this illness. She has now had her operation in St. Thomas's Hospital, London. She has been on antipsychotic medication that seem to leave her empty, no interest in anything, sleeps most of her time away, still not eating, never smiles. I hope the operation would change things, as she has had the offending parathyroid removed, but I'm forming the opinion that the antipsychotic medication is smothering any improvement there could be from the operation. Do you think this could be happening? She had the operation in January. Wow, I'm so sorry for your daughter, because she must be suffering immensely, and I'm sorry for you, because watching your loved one going through psychotic episodes is just devastating. It's just devastating. You know, there's not enough I can say, and not enough, sympathy that I can give, because it is a hard one. It really is hard. And then pinning your hopes on a potential treatment that can help is a hard one too. But putting that aside, you need to look at her calcium, PTH, and vitamin D. She had it in January. I would check those numbers over and over again, right? And I would do it once a month for now, right? And if you see that her calcium and PTH both have come down and are trailing in the normal range and now responding appropriately, her vitamin Ds are normal, her magnesium is normal, if all those things are done, which I know it's hard to do right now in the NHS system, the medical system in England right now is asking and getting labs on a regular basis. But if you can manage to do that with the help of the family physician that you have, then you can distinguish, because if you know for a fact that her numbers have normalized and they're staying steady low, then you may consider in consultation with the psychiatrist, seeing if you should decrease the dose or to get her off, and and seeing if things change, because the antipsychotics cause immense amount of sleepiness, all right? And especially if they're combined as an antipsychotic and an antidepressant combination, they really leave people feeling empty, you know, like they're void of emotions, they're void of an affect, right? And I think that's the only way you can do it, because if the numbers have come down, they have an opportunity to test. If the numbers haven't come down, right, then you have to question whether she's been cured, and she may have other parathyroids. And I think these are very important distinctions you need to make, because you are facing a tough situation, and please make sure you engage all your doctors in it, okay? And Pauline, I can look at your numbers and I can give you my thoughts anytime. Email it to me and I'll be happy to do it, all right? Best of luck, my dear. Agni Solomon. You're welcome, Agni. Thank you for continuing to help people and your patients. My pleasure. 2-gland parathyroidectomy in January 26, 2022. Was not told to take any calcium or vitamin D or magnesium. Shooting in the dark on my own here. Endocrinologist appointment not till July. Some things have improved post-op. Back pain got worse, however. Agni, first, you don't need an endocrinologist at this point to guide you, right? I think if you can talk to your primary doctor and just get a calcium, PTH, vitamin D, and magnesium levels, right? Then you can assess where you stand, all right? Because those who have a version of hungry bone syndrome are going to continually try to get back the credit of calcium that was leached out of the bones, and will continually suffer and have a much harder recovery and need calcium vitamin D replacement. If your magnesium is low, magnesium helps stabilize calcium sensors. And so you may need replacement of a lot of things. So you need your labs to guide you on that. And I wouldn't wait till July. I mean, these are 4 very simple, inexpensive labs, and your primary doctor can order it. You can go to any laboratory, get it done if you live in the US. And if you live in another healthcare system, you know, again, very cheap, inexpensive labs for someone who just had surgery for parathyroids. And you can get an answer and guides you as to which direction to go, all right? Carolyn Bertram. Can high alkaline phosphate be a sign of hyperparathyroidism? It can be. It happens later in the disease process where the bones are breaking down a lot, but it can be caused by many other issues. And it is something relatively serious to look at. It can be caused by kidney disease, it can be caused by bone disease, it can be caused by tumors being in the bone and causing breakdown of the bone. So if that's the only singular thing you have, then you should thoroughly investigate it. But isn't, because she goes on to say, my calcium level is low, high, and my PTH is elevated. Vitamin D is normal. ENT said, I'm not a candidate for surgery. I have horrible symptoms. Scans are inconclusive. I don't know if this is related, but a brain CT scan I had done many years ago showed calcium buildup. I'm confused and wonder if I should pursue further investigation. Without a doubt, you should pursue further investigation. You know, you may have normal calciumic hyperparathyroidism. For you, I would suggest getting a full set of labs, right? And the full set of labs includes calcium, ionized calcium, PTH intact, 25 hydroxyvitamin D, 125 dihydroxyvitamin D, a complete metabolic panel, magnesium and phosphorus, a 24-hour urine calcium and creatinine, done all on the same day, fasting in the morning, right? For the 24-hour urine calcium, you have to actually get the bucket in advance and pee in it from the morning before to the morning where you go in and do the blood test. And you don't have to fast all 24 hours, you just have to fast for the morning where you go do the blood test, right? And look at all these parameters. You may have to repeat the blood test component one more time at 8 o'clock in the morning to see if the relationship between calcium and PTH, is it inverse or is it not following an inverse relationship where your calcium is staying here and your PTH is just continually high, right? Despite a normal vitamin D, despite other potential reasons for having an elevation in PTH. And if there is, so elevations in PTH can happen for a variety of reasons, and this is the chart you should keep in mind. Secondary causes of PTH elevation: vitamin D deficiency, which is correctable; low calcium intake, which your 24-hour urine calcium can show if your calcium is low, right? Renal leak, which shows normal calcium, high calcium in the urine with a lot of kidney stones. Kidney malfunction, these medications, lithium, like Frank was talking about. Malabsorption, right? And low magnesium, right? So these need to be investigated also. So you need to do tissue transglutaminase antibody levels. The kidney function will be looked at, and all these other parameters will be looked at by the test that I mentioned. So that's what you need to do, Carolyn, to figure out where you stand. But if you're feeling horrible, you also need to do a bone density study or a DEXA scan to see where your bone density is, because if your bone density is low, inappropriate for your age, that is also another reason to take action. All of these need to be done in order for you to know. But for me, personally, symptoms are the major driver to treat people, because when I talk to a person and I get the sense that they have all sorts of symptoms that they know started all of a sudden 2 years ago. I didn't do anything. I don't have any illness. I don't have Lyme's disease. I don't have autoimmune disease. I've looked everywhere. I can't find any other answer, right? And I know that this is not my body. This is not how my body feels, and everything changed. Those are the things that parathyroid patients suffer from. They know that this happened. They know the point when things started to change, most patients, and that they are not themselves, and so, and then not every patient has the same symptoms. Majority have fatigue, majority have thirst, majority have frequent urination, the muscle achiness, bone pain, weakness is the most prominent thing. Brain fog, inability to concentrate, irritability, anxiety, and so on. All right. Anyways, best of luck, my dear. You just need a thorough workup, if you haven't already had it, or you may need to find another surgeon for you. That your ENT may not be the right one, and you may have not had the correct scans done for you, as we were discussing earlier. Okay. All right. Moving on. Best of luck, Caroline. But moving on. Yolanda Miad. Hello, Dr. Larian. I'm a 54-year-old woman. I'm in the beginning stages of my diagnosis after doing my own research and pleading with my doctors, as it's happening nowadays a lot. My endocrinologist said it's possible that I have hyperparathyroidism. I'm with Kaiser, and the approach is always wait and see approach. Yolanda, I used to work for Kaiser, and I lasted 4 months at Kaiser, and it's because of that. Now, I do have to say one thing about Kaiser, is that if you're a squeaky wheel and you scream loud enough, you'll get what you need, but most of us are not that way. Most of us think we go to the doctor and the doctor's going to do the right thing, so be loud, and you can get most of what you need at Kaiser. But moving on, I've been in severe pain for many years, and I believe the hyperparathyroidism could be causing my symptoms. With that being said, I take 5,000 units of vitamin D every day. Before the last 2 labs, I bumped my vitamin D to 55,000 units a week. I took 500 milligrams of calcium a day. With the limited information I've given you, do you think I am a candidate? If so, what can I tell my doctors? I've been dismissed for many years regarding the pain I'm suffering here. My numbers listed below since 2014. None of these were taken in the morning. I was not aware until recently that it was the best time to do the labs. Most have been taken in the early evening or later. All right, so calcium is 10.2, PTH 46. So calcium is the upper limit of normal. That was 2014. 2015, calcium 9.5, PTH 30. Now, interestingly enough, she also gives the ionized calcium, which is a more accurate measure of the calcium in your bloodstream, this is the free-floating calcium, is 1.34, PTH was 46. Next time, calcium was 1.38, PTH went down to 30. So calcium went up, PTH went down. Next time, in 2020, so 5 years later, calcium, ionized calcium is 1.34, but PTH now is 74 and vitamin D is 30. So vitamin D is normal, in the lower range of normal, but normal. Next time, December of 2020, calcium is 9.4, PTH is 90. So the PTH is rising up, right? Next time, August of 2021, PTH is, calcium now is a little bit higher at 1.37, and that's ionized calcium. Regular calcium is now a little higher at 10.1, and PTH is 56. So it's not low, it's in the high normal range. September of 2021, calcium is 9.5, PTH of 57.2, vitamin D 58, 24 urine calcium 162.9. And she has a huge list of symptoms. All these symptoms are potentially parathyroid related. Okay. She has a heart valve abnormality, which is not related, but heart conduction and beat abnormality, which can be related. 7 thyroid nodules with calcification, which can cause the scans to be inaccurate. Listen, Yolanda, based on the numbers, I cannot tell you with certainty. Based on your symptoms, you're a textbook patient, right? So you're the type of patient where I try to do the labs with consistency and see if I can see a pattern that guides me towards it. So I would say, do the calcium, ionized calcium, PTH, 25 hydroxy and 125 dihydroxy vitamin D at 8 o'clock in the morning, fasting. Make sure you're not taking biotin supplements at all for a while. And I would repeat it 3 times at 8 o'clock in the morning, and it can be 1 or 2 weeks apart each scan. So you can get this done within 3 weeks, right? And then look at the numbers and look at the patterns and discuss it with your endocrinologist. You can have your primary doctor order these, and then you can look at the pattern and discuss it. And you can take it from there. Because right now, I can't tell you with certainty. Now, there are times when patients present yourself with like this, and I do the labs and they're still not clear, and that's when I would do an ultrasound and a 4D CT scan to see if I see a potential culprit, okay? So that scenario can exist as well. Best of luck, my dear. Leslie Halliday New. Lovely name. Hi, Dr. Larian. I love your Q&A sessions. They are very informative. Thank you, Leslie. My question is, I've heard there is a 25% possibility that someone with hyperparathyroidism is also likely to develop breast cancer. Is that correct? I don't think the possibility is that high, fortunately. I think it's much lower. But when you have persistent hyperparathyroidism that's untreated, that it's been reported the chance of cancers increase. There are some studies that show that they haven't increased, and there are many more studies that have shown that it has increased. So it's not a high increase in chances, but there is an increase in the possibility. So I wouldn't dare say it's 25% though, okay? But there is a higher potential, all right? So, in someone who has subtle disease and doesn't have a lot of symptoms and has a strong family history of cancers, I have a very strong family history of cancer. My father had 2 cancers, my mom had 1, my grandparents have had cancer. So I have a genetic predisposition, which is what led me to do genetic testing for cancer genes to see if at least I have any of those known genes, which I didn't. I have an unknown gene probably hovering through my body. But I mean, when you have that history and you have hyperparathyroidism then I would say you should take action, right? All right. So Leslie New, I hope that answers you adequately, all right? Rosalind Bull, I'm a 72-year-old woman with primary hyperparathyroidism diagnosed in June of 2021. Blood at the time showed PTH of 8.3, so I'm gathering that you're using the European system. Calcium 2.79. Rosalind, it always helps me when you give me the normals if you're not in the US, because the normals are very different in each country. All right, but I'm gathering based on your numbers, based on what I remember, that your numbers are both calcium and PTH elevated, and then you have 24-hour urine calcium of 9.3, which I don't know if that's high or low. Vitamin D is 68 on 800 units of vitamin D, which again, I don't know the units you're using, so okay. Kidney function is normal. December 2021, DEXA scan shows osteopenia. At age of 72, osteopenia is not bad. Last blood, March 2022, calcium is 2.65. PTH not given, vitamin D dropped to 47. Advised to take cholecalciferol, which is a vitamin D supplement. Was advised to recheck calcium, PTH, vitamin D in a few months. Is initial diagnosis in doubt? Well, I guess so. I mean, if we're giving you vitamin D and trying to repeat labs, they're trying to see if there was an abnormality, right? I do think you need a more extensive workup, because based on what you're telling me, I can't tell if you had a momentary elevation, or is this persistent thing, right? But it seems like your calcium on March 22nd was not significantly lower than the one you had previously, but without a vitamin D check, I don't even know what to make of it, right? I usually like most patients to have more than one set of blood tests for me to diagnose them with hyperparathyroidism. I just think it's prudent to do that, because you don't want to be taken to an operating room based on one set of labs, basically, unless the labs are tremendously high. You know, the upper limit of normal in the US is 10.2 for calcium and 75 PTH. So if you have a calcium of 12 and a PTH of 300, that's clear, right? But if you have a calcium of 10.4 and a PTH of 75, on one occasion, I'm gonna repeat the labs and see if that's persistently present. So I would do further workup. Louis Anderson. Hi, Dr. Larian. Thank you for your Q&A. My pleasure, Louis. I'm post-parathyroidectomy. My PTH has been 91, 121, and 89 each month since my operation on December 24th. Does it take some time to reach normal levels? How concerned should I be that this isn't over? Very good question and a huge concern. I'd say probably somewhere around 5 to 10% of the patients continue to have elevated PTHs after surgery. Now, majority have normalized calcium and an elevated PTH, and that is probably because they have a version of a hungry bone syndrome, where the bone is grabbing all the calcium back, and your parathyroids that are normal want to counteract that, so the level of calcium in your bloodstream stays normal for all the other organs that need calcium. And so a battle ensues between the bone and the parathyroids, and the PTH stays high until your bones are fulfilled. And that may take 6 months to a year. I would say look at both calcium, PTH, and vitamin D, all three of them, as well as magnesium, right? All four of these I would check for you at this point. Because if these numbers if the calcium is normal and your PTH is elevated, and if your vitamin D is low, then you may just need to take more vitamin D and calcium and supplement until this process is over. Now, you may also have persistent disease, right, which may present in this way, but hopefully you don't. Hopefully you have the hungry bone syndrome, and you need some time to to get to that point where you can figure this out, okay? But you also need the blood test, so do that as well, Lois. Sally JP, hello Dr. Larian. I'm asking this question on behalf of a UK member, Hillary, who remains unwell after 2 ops and would very much appreciate your guidance. It'll be my pleasure to help Hillary. Hillary unfortunately had a failed exploratory op despite a positive scan. She had a second op with a different surgeon who found and removed the adenoma seen on the scan. He said her neck was left a mess by the first surgeon, so he didn't look for the remaining glands. Her PET colon scan didn't show any other issues. Would you please take a look at her levels and symptoms charted below? Note 2 PTH ranges at 2 NHS Trust and offer your opinion, please, for Hillary. Thank you, okay? All right, here we go. Sally JP, if you could tell me when the date of her surgeries were, that would be helpful, because then I can look and see what the impact it had on the numbers. But the dates start from January 2021 and go to March of 2022, all right? Calciums in January 2021 was 2.29, vitamin D was 103, and magnesium was 0.91. So magnesium was, I'm assuming, low, vitamin D normal, and PTH was very much elevated, while the calcium is in the normal range. Calcium rose up to 2.36. PTH now is in the upper side of normal, and the PTH continues to stay normal through all the 9 labs done from February 2021 to March of 2022. So the only elevated PTH was in January of 2021. I'm assuming she had surgery after that. But her calciums are still in the mid-range of normal and on the rise. Sally, do me a favor. Send me, I think you have my email, right? Yeah, you may have my personal email. Just send me her operative report, her pathology report, and the scans, and then again this chart. And I may have to set up a Zoom call with you or with her or both of you potentially, and try to figure this out, because I don't think I have adequate enough information to tell you. You know, she had one time where her PTH was high, and you just say that her surgery was in March of 2021, so in January of 2021 her PTH was high, in February it wasn't, and her calcium was normal. And so I have to look at the more in-depth picture of what was going on to be able to try to help Hillary, all right? And I'm happy to do it, but let's chat, okay, more, because these numbers are not clear enough and I just need a lot more information. And you know, this whole thing about the first surgeon leaving a mess, you know, sometimes surgeons are sloppy, that's true, and sometimes patients heal and form a lot of scar, that's true too, and it's sometimes hard to judge what's what. But again, I'm happy to try to help Hillary, okay? All right, Sally, moving on to Maddie Turner. My son had a parathyroidectomy in August of 2021. He was 15 years old. His calcium was 5.3, PTH was 83. The adenoma was 4 centimeters. Wow, that is massive. His calcium is now 2.51 and PTH is 5.94. He's in the extreme pain with his bones and muscles and often has nausea. Our doctor is telling us it's psychological, as there's no way he can be in pain now. What are your thoughts? Um, well, you have a 15-year-old boy whose bones are growing, right? He's had years and years of calcium depletion. So I would suggest that you do a bone density study. Hopefully he had one before the surgery to do a comparison, right? He's still growing, you know, he's going to be growing for a few, 5, 6, 7 more years, potentially. And it could be that he's playing catch up. That's why he's having the bone pain, right? I don't know the ranges of the numbers you're giving me, so it's hard for me to answer, but I think what you should do, if he was my son, I would do a bone density. I would get a calcium PTH 25 hydroxy, 125 hydroxy vitamin D, and a 24-hour urine calcium now, right? Because the 24-hour urine calcium is going to tell you how much calcium is being filtered out. The kidney is amazing because it has the calcium sensor at knowing what the level of calcium in your bloodstream should be. So if the level of calcium in your urine is very low, that means your son needs a lot more calcium to fulfill the needs of the bones. If the bones are not getting what they need in a growing boy, then they're going to be painful. You know, some kids have growing bone pain, bone pain as growing, we call them growing pains, right? And it could be that your son is going through a catch-up, for this, okay? But I really need to see more numbers, and you need to see more numbers to be able to correctly figure this out, all right? Best of luck, Maddie, and I'm here for you, okay? Sally JP, you're back. I'm asking this very unusual question on behalf of Des, who has a focused parathyroidectomy in 2017, age 67. She had very low vitamin D and has experienced severe tingles and vibrations. Since her surgery, which got worse when she took vitamin D, even at a very low dose. Des began taking magnesium glycinate 2 years ago, which enabled her to begin taking vitamin D. And she finally managed to get her vitamin D into range, but the tingles and vibrations persisted. She has also experienced itchy and weeping skin lesions, which have baffled doctors. She also gets heart palpitations. Wow, poor Des. A few weeks ago, Des experienced 2 violent thumps in her heart whilst lying in bed. She was too scared to sleep as she thought she was about to have a heart attack, but the vibrations and tingling stopped. Her blood pressures had dropped. Des has monitored her blood pressure twice a day since then. She found that the tingling and vibrations ceased when her blood pressure was low, and she had mild tingling when it was with a heart rate of 58. But the violent throbbing vibrations and tingles came back with a vengeance when her blood pressure became elevated. Okay, so obviously everything she's experiencing is blood pressure dependent. Des had had some recent blood tests and found that her calcium is 2.62 with PTH of 9.3. Not sure for the range used, so it might be 13 to 88. She had requested a follow-up appointment with a surgeon who did her operation in 2017, but no appointment is available until May. We are now wondering if her symptoms were actually indicating she wasn't cured in 2017, although the removal of the adenoma reduced her calcium from above 3.0 but wonder if you might have understanding of what might have happened to her heart that night and how wide it appears to have calmed the vibrations, since she's really suffering from her palpitations at night though. All right, Sally, you're challenging me yet again. Poor Des though. Listen, the calcium of 2.62 seems to be on the high side, so I would have to see the range again for the UK system, right, at the time, and the PTH is also, because I'm not sure if it's, just the last one that you sent me had 2 different ranges for PTH, 1.6 to 6.9 and 15 to 65. So it's based on the units used, and most of the UK system uses the the range, which is 1.6 to 6.9 based on what I've seen. So if that's what they're using at a PTH of 9.3, that's elevated, right? So 2.62 is on the upper limit, it's just above normal for calcium, and 9.3 is above the range, which comes to 6.9, right? So it seems based on her number that she has persistent hyperparathyroidism. That's one. Two, with hyperparathyroidism, you can get high blood pressure, erratic blood pressure, erratic heart activity. So if she's having, instead of rhythmic heart movement, she's having erratic at times, which is the thumping that she feels, then that could be part of hyperparathyroidism. So it is a problem, but she has to do two things. She has to obviously see a heart doctor, right, and get the heart monitoring done, because hyperparathyroidism can deeply affect the heart. We know we know there's receptors for PTH in the heart. We know that people who have long-standing hyperparathyroidism get thickening of the heart muscles, right? And they get abnormal rhythms, so the thumping and so on makes sense. The tingling, tingling can happen from low calcium. Tingling can happen sometimes from high calcium. Tingling happens when you compress a nerve, so you're not feeling it, like when your arm falls asleep. Tingling happens when there's not enough blood flow to the tips of the fingers, right? So is it possible she had calcification and stiffening of the blood vessels, causing blood pressure issues and causing lower blood flow to the fingertips? Yes. I mean, Des needs a lot more investigation, right? I am concerned, and I would strongly urge her to see a cardiologist, and then she can do the labs that I keep saying now, fasting in the morning, just to see what those numbers, how they're trending. Between now and May, where she sees the surgeon, she should do multiple set of labs, so that when she sees the surgeon, those labs are in front of him, and he can follow the pattern and take it from there, and do it in the same lab, fasting at 8 o'clock in the morning, make sure she's not taking biotin, and see those numbers and share it with us as well, right? But she needs to see a cardiologist. They have this test called a Holter monitor, where they put a monitor of heart rhythm for a couple days. She takes it home and they look at the rhythm, and she could record her blood pressures at different times of day, so that they can correlate it with those rhythms. So when she's having palpitations or tingling and so on, she could record the blood pressure and then show it to the cardiologist, because at the same time the cardiologist can see what the rhythm of the heart is, and that can be very informative as to what's going on. Okay, hopefully that helps. All right, JMRW. Does vitamin D 125 labs in the normal range count for good levels of vitamin D, even if vitamin D3 labs are low? No. So let me see. Bring up and see if I have vitamin D units for you to look at. Okay, so let's see. This is what I want to show you. All right, so 25 hydroxyvitamin D gets transformed into 125 dihydroxyvitamin D. And that happens because of PTH. Sorry. So Your units of 25 hydroxy vitamin D is nanograms per milliliter. The units of 125 is picograms per milliliter. So by a factor of 1,000, this is higher, right? So a small amount of this transforming into that is all that the body needs to do its job. So in terms of your question, if this is normal and this is low, what does that mean? Well, it means that your body's working hard to maintain this at a normal level, right? And because this is happening only in the kidney while all of this is free floating in all of your body, in all of your blood, right? And this goes through many different processes to get to its final point, right? It goes from the skin, transforms into vitamin D3, cholesterol essentially is transformed into vitamin D3 in the skin, and then it goes in the liver, gets transformed again. So there's many different steps involved in getting an inactive precursor to the active vitamin D. So now the active vitamin D acts in the calcium system. In other parts of the body, it may not be the same. So you want to correct the vitamin D3, the 25 hydroxy vitamin D3 as well. So although the 125 is normal, if your 25 is low, you should definitely supplement it, yeah, right? I don't know if that helps you, because I was going all around to answer your question, but hopefully it does. Heidi T7777. Hope you'll all be discussing foregut hyperplasia. Thank you. Heidi, you should ask a more specific question, my dear. I'll be happy to answer, all right? Because foregut hyperplasia is a problem, and it's what we're talking about, all right? Anyways, Crown 36, how relevant is phosphorus levels in diagnosis? I know calcium and vitamin D are must-haves, but would low phosphorus be relevant? In the kidney, when calcium is taken out, the phosphorus is brought back in, right? So when your calcium levels are changing in the paradigm of hyperparathyroidism, where the PTH is preventing the kidney from releasing calcium, which you can see here, right? The PTH goes to the kidney and says, don't absorb calcium, give it back, right? So calcium comes out, phosphorus goes in, right, into your urine. So early on in the process, you have two fighting things going on. You have an elevation in your calcium, so the kidney's trying to filter it, and you have an elevation in PTH, which is telling the kidney not to filter it. They're fighting each other. So early on in the disease, you may not have elevation of calcium in your urine because these two processes are fighting each other, and the phosphorus levels may be normal. So I'd say a great majority of patients that I see don't have low phosphorus levels, or have rather normal phosphorus levels. So that when you do have low numbers, it's further confirmation of the hyperparathyroidism diagnosis. But if it's normal, it doesn't say that you don't have it. Okay, hopefully that's just helpful. DJ S Chak, how long after surgery should it take for PTH to get stabilized? Almost a year enough, and the PTH creeps up, but calcium stays in the high normal. Well, DJ, I would say that that is not normal. A year later, if your calcium is high normal and your PTH is going upwards, that looks like persistent hyperparathyroidism. For someone who has your numbers, I would do the labs. She's asking how often should the labs be done, he or she. And I would say that I would do it monthly. I would do calcium, PTH 25 hydroxy vitamin D, 125 and magnesium level on a monthly basis, fasting in the morning, just to see, because if the numbers are going up, you have persistent disease and you need to look at it. Dawn Clarice Brown is asking, my hyperparathyroidism is cycling. Is that possible? Well, it depends on what you mean. If you mean in terms of symptoms or if you mean in terms of labs. Well, because if you're asking about labs and you're saying that sometimes your PTH, okay, let me go to the, so this is when hyperparathyroidism from an adenoma develops, right? It's alteration in the set point, right? And then this one is set point 11, right? And this one is 9, the normals are 9, and this one who's aiming for 11 basically hijacks the system because the normals stop working because the curve comes down, right? And then turns into a tumor and tries to aim for 11. But even at this 11 number, you can see that sometimes the calciums are higher, sometimes calciums are lower, sometimes the calcium is in the normal range. Sometimes the PTHs are low and sometimes the PTHs are high. And so you can have these kind of alterations in numbers, right? It is this curve that tells you the story, meaning the relationship between calcium and PTH, right? That's what's important, okay? All right, hopefully that helps, Don. And Crown 36, hope you discussed why the hell do numbers jump around in some people so damn much. There you go, I just did, Crown. Hopefully that helps. All right, now moving on to the questions that came in as we were talking. It seems to be a fair amount of them. All right. Claire Russell Foley says, what scan was done to locate the tumor, the one that I was talking about originally in the jaw area? Well, before the second surgery, they saw it on the 4D parathyroid CT scan, but they took out the wrong thing. They took out a lymph node so they took out a lymph node. I see the incision of the surgery here, and it was a small incision. So they took out a lymph node somewhere around here. They didn't go high enough, right? But it was seen on the 4D CT scan, right? And it was ignored because they took it out and it was a lymph node. They just hadn't gotten to the right location, right? That's where the experience of the surgeon matters. But the particular surgeon that did this surgery, I personally know, and he's a very good surgeon. So even in the hands of a good surgeon, tough cases like this can be missed, right? Next is that she had repeat scans which ignored that lesion because they said, well, it was a lymph node, and there may be other lymph nodes, whatever, right? It's the PET choline that finally showed only activity up there again and brought all of our attentions back to that. And I also feel to blame because I assumed that the first surgeon had done the right thing and gotten the right tumor out. One of the first dictums in medical school they teach you is don't even trust your mother, which is terrible to say when it comes to medicine. You always check and recheck yourself, right? Any case, so the 4D CT scan from years ago had shown it. When we did the PET choline scan, it showed it there, and then when we superimposed the old 4D CT scan with the new PET choline, we're like, wow, it's the same lesion. They just never got to it. And based on the video that I showed you, it was so far up that it was a little daunting getting up there. And you can see that it's in the sheath of the nerve of the tongue. It's immediately next to the carotid artery and the jugular vein. The visuals all the way up there with that high mag camera that I put in were fairly good, but it's not so good, as you're in there and trying to do surgery. It's a very small space. It's hard to do the surgery, right? In any case, so that was it. Moving on. Claire Russell Foley, I have had 2 failed surgeries. I'm now taking Sensipar. Fantastic. I really have. I'm becoming very fond of Sensipar more and more. I am in 2 scenarios. In one scenario like yours, Claire, where you've had failed surgeries and you're using it now, and a lot of my patients are using it and find it helpful and stick with it. And in the scenario of diagnosing, when someone's diagnosis is not so clear, numbers are not so clear, sometimes giving them Sensipar to bring down the calcium and PTH even further and seeing how they feel helps, because it helps guide you as to what to expect. So bravo, Claire, good for you. Tammy Morella Hortenbauer, what would you expect a PTH to be in a person whose calcium is 10? Well, again, it really has to do with this, right? So if your set point is 9.0 at a calcium of 10, your PTHs should be 10, 15, whatever, low. Range of normal being 15 to 65. However, if your set point is let's do it in black. If your set point is 10 and you have a graph that looks like this, at a calcium of 10, your PTH should be 50. So it is not a question that can be answered like that. It really has to do with your graph, and nobody knows their graph, unfortunately, unless they're healthy, normal, and do a massive amount of PTH and calcium testing where they can create a graph for themselves. And no one does that. So unclear, my dear. Mary Elizabeth, back in November, I passed a kidney stone. Prior to that, having terrible symptoms, history of 2.5 glands removed. My endocrinologist thinking calcitriol is causing stones. Doctors had me stop the calcitriol, decrease the calcium 650, and started vitamin D supplements 1,000. All right. So, Mary Elizabeth, I don't know if you had kidney stones prior to your parathyroidectomy, and I don't know what your numbers are now. So, those would help me be able to help you. If your calcium level after surgery and your PTH levels are significantly lower, right? But in the normal range and reacting appropriately, right? Then you don't really need supplements, right? And you may not need the calcitriol. Right? Calcitriol is for someone who's not making adequate amounts of PTH, right? So if your endocrinologist is giving you calcitriol, I'm assuming the 2.5 parathyroidectomy caused you to become hypoparathyroid, right? Which means that even though they looked at 2.5 glands, even though they took out 2.5 glands, the 1.5 remaining glands are not functioning adequately, and they were injured during your surgery, which is part of the reason I don't like to do bilateral explorations on everyone, right? In any case, there's a lot of unknowns for me to be able to give you an answer. But if you're taking calcitriol, presumably because you are hypoparathyroid, and if that's why you're also taking calcium, then you need to look at your 24-hour urine calcium to see where that stands and try to see how you can modify that, because you may be causing a kidney issue at the same time as well, so you need to look at the kidney parameters as well, all right? I know that's not an adequate answer, but we need more to be able to help you. Elena Lanunziata, pretty name. Is there a recording of this? I really want to keep watching and learning, but I have to work. Yes, Elena. This will be on our Facebook page, and you can come and watch at any time. And there's more of them too, so you can listen to it. Leslie Halliday New. Oh, we already talked about it. She goes on. She had asked, is there a 25% chance of getting breast cancer if you have hyperparathyroidism, and the chance is lower, fortunately. Is this because of the hyperparathyroidism, or simply an unfortunate occurrence, seeing as most hyperparathyroidism sufferers are women, and are breast cancer sufferers. I mean, there is that, of course, but it also, I think what it does is that when you have hyperparathyroidism and your body runs inefficiently, it increases, you know, I'm about to tell you something that's controversial and you may think I'm crazy, but bear with me a little bit. Your immune system is designed to protect you against infection, but it also does surveillance of your body to check to see if any cells are changing and becoming cancerous or becoming abnormal functioning, right? When they find those cells, they kill those cells. They eat through those cells, right? Your immune system is an incredible system. It does an amazing job. It's why we can exist, pretty much. If you didn't have a functioning immune system, you'd be getting infections and cancers like this. That's why patients who have HIV, immune deficiency, because of HIV, right, they get cancers and they get infections. That's why when we put people who get heart transplant, kidney transplant, liver transplants on immunosuppressants so it doesn't attack this foreign organ, those patients are prone to cancers and infections, right? And so your immune system is doing this all the time, right? Most of you who are here on this, including me, have already had a precancerous or a cancer, but your immune system has already taken care of it, all right? This is the controversial part, right? This is the part that blows up. On those particular days when you wake up and you feel like, I think I'm coming down with something. It could be that you're coming down with a cold, but sometimes you feel like you're coming down with something and then, by the afternoon or the next day it's gone. You didn't go to work because you're like feeling not so well. Those are the days where your immune system is using its weapons of mass destruction and its chemical warfare internally to fight a fight. And some of those times are bacteria and viruses and infections, and some of those times are cancers and precancers and cells that are going in the wrong direction. So if your body runs inefficiently when you have hyperparathyroidism and your immune system runs inefficiently, the chance of making a mistake and not attacking a cell that's heading towards a cancerous process is more. Can I tell you that that's a fact in terms of the parathyroid, and I know that's a direct correlation? No, but that's what I'm assuming is happening because I don't know the exact process. But that could be the process which is leading to the increased potential for cancer development. All that this is trying to tell you is that your body is amazing and incredible. It has amazing capabilities. It really can do so many things above and beyond our wildest imaginations. We can keep going on and making nanotechnologies and robots, and nowadays robots that walk like humans, but they cannot function like a human. Our functionality is supreme, you know. Millions of years of evolution have brought us to this point where we are this magnificent thing, right? And magnificent, intricate things, when they have something go wrong, they go wrong, you know? I was exceedingly poor during all my medical school and training and residency and everything. Poor, dirt poor, right? As soon as I got out and I made some money, I bought this very nice European car, right? And I was so happy with it. I was just like floating, right? To drive this car and feel great, right? And I'd been wanting this car forever, right? Anyways, it doesn't rain in California so much. It rained a lot and there was a huge puddle of water, and I was driving and I go through this puddle of water, and some of that water probably got into the electrical circuit of this damn beautifully engineered German car with all this intricacy and terrible electronics, right? And this car, 6 months into me owning it, started not functioning. It broke down 6 or 7 times. I had to tow it into, and it was all just one tiny little thing, one tiny bit of that electronic in a massively complicated, highly technologically advanced, which every part needs to work perfectly with the other part. Just one thing went wrong and this car was kaput. It was the biggest torment of my life from that point onwards, right? Until I could convince the company to take it back. In any case, our body's intricate like that. So when you have some process go wrong, it can really have a domino effect on all sorts of other systems. All of this is saying to you that you have to always optimize and respect your body. You know, give it love, give it good health, give it good sleep, eat well, avoid garbage food, avoid sugars, avoid the things that your body evolutionarily didn't see. I'm not saying never have a cake or never have a sugary sweet or ice cream. I'm just saying have it infrequently. Be reasonable with your body, and your body will serve you well, because things naturally go wrong with your body. You don't want to add to that. You don't want to contribute to it. But I digress. Moving on. Joe Carroll Hughes Siborowski, aka Fonzie, writes, "Hi Dr. L, after 3 failed surgeries and then 4 ethanol ablation procedures in January, my calcium PTH labs have normalized." You just made my day, Fonzie. You really did. I still have most of the non-specific symptoms. Can you address why, if you had hyperparathyroidism for 15 years, your body might not readapt to a new normal? Well, and she writes, XO Fonz. I love you. I love you, Joe Carroll. Anyways, listen. When your body is designed to have a calcium of, let's say, 9.0, right? Your nerves, let me show you this, just as to simplify it. Your nerves function by, so this nerve, when it sends a signal and it gets to the endpoint and it tries to communicate with these muscle fibers, right? These are muscle fibers, right? Or when it comes down and tries to communicate with another nerve, the way that communication happens is that the signal comes down, and when it gets down to the end, right, it opens up calcium channels. And calcium rushes in. The amount of calcium channels it opens up is based on the intensity of the signal. So if the signal is intensity 90, right, and gets down, I'm grossly simplifying, it opens up 10 calcium channels, right? If your calcium is supposed to be 9.0, when you open up 10 calcium channels, you get 90 calcium elements coming in, and 90 calcium elements results in neurotransmitter, let's say dopamine, right? Dopamine coming out at the intensity of 90, and a signal of magnitude 90 goes to the next one. But if you have hyperparathyroidism and your calcium is, let's say, 11.0 instead of 9.0, and you open up 10 calcium channels here, you have 110 calciums coming in. The signal that goes is 110, right? So your nerve is misfiring, right? Now your muscles have to learn that, oh my God, when a signal of 110 comes, it's a little bit of an over-adjustment. Now I have a tremor. Now I have muscle weakness. Now I'm doing this inaccurately. I'm not as dexterous as I used to be, right? I have pains, so I have to take it easy. You start going through these compensatory mechanisms, right? And your nerves are compensating for the misinformation that's coming through. Your muscle realizes that there's misinformation, it tries to compensate. Your kidney realizes there's misinformation and malfunction, it tries to adjust. Your blood pressure goes up because you have hyperparathyroidism, so now your heart has to pump differently. Your heart's getting missed signals because of hyperparathyroidism. It misses signals, so your kidney blood flow changes. Your kidney needs to compensate. So everything is not only compensating to the increase in calcium and increased PTH, they're also compensating to each other. It's malfunctionality or inefficient functionality. Once you correct everything, so for years and years you've had to adapt. Your calcium didn't go from 9.0 to 11 overnight. It took a while, right? So it took a while to get up, and now all of a sudden your calcium and PTH comes down, and all those organ systems that had to compensate and get up here now have to compensate to this, right? And make adjustments to it, but the other organ system that has to not only adjust to the calcium and PTH, but also the functionality of the different. So it takes a long, so what I tell patients about their symptoms is that the higher the difference between your calcium, normal calcium, and the calcium that you have, and the longer you're in that state, the longer you're going to take to recover, and the more uncertain you are of how much of those things to recover. Because, for example, in terms of blood pressure, you can get high blood pressure because in your adrenal glands, the renin-angiotensin system is sensitive to PTH, and you can get that because of a hormonal effect. Or you can get calcium crystallizing into your blood vessels and stiffening your blood vessels and causing elevation in your blood pressure. So when you have high blood pressure because of hyperparathyroidism, you don't know if it's because of the renin-angiotensin hormones or if it's because of stiffening from calcifications. And so some things become uncertain. Obviously, if you have hyperparathyroidism for a longer period of time, there's more likelihood that you may have calcifications of your blood vessels, right? And that's why you gotta really, if you have hyperparathyroidism, you really need to check yourself all the time. Keep close eye, get a Fitbit watch and watch your rhythms and watch your sleep patterns and watch your heart rate and blood pressure and everything, you know, and your ability to, you know, you check and see, I 2 years ago, I could run 2 miles, no problem. Now at 1.5, I'm huffing and puffing. Something's changed. You got to be aware, right? So that's why, Fonz, that's why it takes a while, my dear. But the more you force the issue, the more your body learns to adapt. By that I mean, the more you exercise your body and do different things, right? Different types of challenges, short sprint and a long marathon. Not necessarily doing those things, but as an example, the more you challenge your body physically, the more it adapts. Your superpowers as a being are obviously your consciousness, number one, your immune system, number two, and the most important thing is your adaptability, right? You're able to adapt. You walk barefoot, you get thick calluses on your feet so you can walk on sharp things and be okay, right? We are adaptable, right? And so you have to force the adaptation physically and mentally. So crossword puzzles, challenges, that you keep challenging your brain to adapt and learn how to be full funds again. All right, my dear, you made my day. I just can't tell you how happy I am. And this should be something for everybody else. Sometimes surgery is not the solution. Sometimes you can find an alternate path like the alcohol ablation, which is injecting alcohol in the target where you think there's something there. And it's an area that's hard to get to surgically or find, and so on. Well done. The reason Fonz is because she's unstoppable. And I love you for that. All right. So Elena Lananziata says, I'm 47, my calcium is 10.6, PTH is 56, vitamin D is 36. Terrible symptoms that I was told are all perimenopause. No, my dear. At a calcium of 10.6, your PTH should be lower, right? So if you repeat the labs, your vitamin D is 36, so it's normal. If you repeat the labs, again, fasting at 8 o'clock in the morning, 1 week apart, 3 times in a row, and you find that your vitamin D is persistently in the normal range and your calcium is persistently high and your PTH is not suppressed and doing this thing, remember the curve has this, which means you keep going, a normal person keeps going up and down the curve, while a hyperparathyroid patient is aiming towards that higher number of the curve and it persistently has high numbers. So if you have 10.5 and a PTH of 57, something like that, you have normal hormonal hyperparathyroidism. Okay, so hopefully that helps. And no, you know, she writes, Elena writes that I was told my symptoms are all perimenopausal and depression psychosocial. No, sweetheart, it is not true. I hate the fact that women get boxed into these categories, right, and dismissed, right? It's just, I really dislike. You can tell how much I dislike it because, you know, boxing a person into this category, oh, you're just perimenopausal, you're hormonal, right? Or you're just an anxious woman, right? Oh, you're hysterical. That's where the word hysterectomy comes from. Hysterical, right? Is just laziness by the doctor. Okay? It's just, and it's also ignorance because they don't know what conditions also can cause this and how hyperparathyroidism can manifest. Then they give you all this baloney BS diagnosis. You have fibromyalgia. There's a European study that showed 25% of people diagnosed with fibromyalgia actually had hyperparathyroidism, and a great majority of them had normal calcemic hyperparathyroidism. Right? Another boxed-in diagnosis, right? In med school, they taught us that when patients come in with a diagnosis 20, 30 years ago, right? With a diagnosis of fibromyalgia, that means they're crazy. They just didn't want to tell them they're crazy, right? That's tragic, I think. It's just tragic, right? And this poor person could have had something that's curable and made better. So, Elena, use your female powers. Be strong and fight, and you'll get to the answer. Because to me, it looks like you have normal hormonal hyperparathyroidism. Davina Reyers, can this illness cause pain and spasms in the legs? Yes, it can. It can. I mean, there's all sorts of other things that can do this too, but it can. Elena asks, is there connections between Wellbutrin and hypercalcemia? No, there isn't. Not that I'm aware of. Mary Elizabeth says, my calcium is 9.8, vitamin D 48, my PTH is 70. Past kidney stones in November of 2021. My new endocrinologist thinks calcitriol may be creating stones. Calcitriol suppresses the parathyroid glands. If your PTH is 70, which is above normal, it's not suppressed. And a calcium of 9.8, so I don't even know why you're taking calcitriol. When you have vitamin D of 48, you have adequate PTH production. To me, it looks like you have persistent hyperparathyroidism. Mary had previously put a message up about having painful kidney stones after a 2.5 gland parathyroidectomy, if I remember correctly. And I was asking why she on calcitriol. Calcitriol for people who have hypoparathyroidism, which she doesn't at a PTH of 70. So I think you have persistent hyperparathyroidism, my dear. And I think you need to do that. Oh yeah. She had 2.5 gland removed in 2008. If you had 2.5 glands removed, that's presumably because you have parathyroid hyperplasia, right? And they couldn't find the 4th gland. Usually this is what happens. They can't find the 4th gland. They find 3. Because 3% of people have only 3 parathyroid glands, they said, okay, maybe this is a subtotal parathyroidectomy. I'll leave half a gland. And it could be that you had 3, that half a gland since 2008 till now, in the past 14 years, has grown, or that 1.5 gland that you have has grown and is now causing hyperparathyroidism again. So best of luck, Mary Elizabeth. Get it treated. All right. Christine Cullen. Hi, Dr. Larian. Christine Cullen in Denver, wondering if you have received my ultrasound result. Christine, I don't think I should. Okay, here. I don't know if I've received your ultrasound result, but listen, email me separately because I don't want to talk about a non-parathyroid issue. That's your private issue in a big group. But I email me and I'll look into it and find it. But I was on vacation last week, so I'm still playing catch up, and I'll look into it. I'm just writing it down. All right. But I'll answer you. I read the whole thing. I do think you should do the needle biopsy of the lesion that potentially could be a cancer. But I'll get back to you in more detail. All right, moving on. Pam, can you explain, Pam Farniak, can you explain the effects of the effect hyperparathyroidism has on kidney function? Well, hyperparathyroidism, because the calcium level is higher, you have increased calcium in the kidney, which predisposes you to kidney disease, and your kidney now is working harder to get rid of calcium, and the calcium can calcify and form sediment in your kidney, so it can cause kidney disease to progress. No, and she says, I have stage 3 chronic kidney disease. Well, if you have stage 3 and if you have hyperparathyroidism, your hyperparathyroidism needs to be definitely addressed. That's one of the indications for surgery for hyperparathyroidism in a person that has no other symptoms. If their kidney function is low, they need to have treatment. So please seek treatment quick. I'm rushing through these because I have to get off this quickly in 5 minutes. Mary Jo Gibney Hoshtel. Prior to right side thyroidectomy years ago, now need parathyroid operation and possibly left side thyroid out. Would you check all glands or stay away from the scar tissue if you found an adenoma on the left? If I find an adenoma on the left side, the untouched side of your neck, and remove it and your PTH comes down appropriately, then I'm not going to go on the opposite side that has scarring. If on the other hand it doesn't go down, that's the reason to go look in the other side. So I have a very good indicator of what I should be doing. Let's see. Kim Levi Amick. 3 months post-op with removal of one parathyroid and a thyroid nodule, along with a very small slice of my thyroid. I'm now hypothyroid with very low T3 levels. And so Endo says this is not related to my surgery and that meds will not. Well, Kim, the thyroid gland produces essentially 2 hormones, T4 and T3. When people have a normal T4 and a low T3, we call it a sick euthyroid syndrome. Euthyroid means normal thyroid levels, but the person is still sick because their T3 levels are low. And that can happen because their production is low, or the enzyme that transforms T4 into T3 is not functioning adequately, in which case they need to get T3 supplementation. So you may need to take that. And that could be caused, if you're making adequate T4 and not enough T3, then probably is not from the surgery. You probably were borderline before, but regardless, if you're having symptoms from hypothyroidism, then you got to take T3 supplementation. So Mary Jo Gibney says, I had breast cancer in 2018 and now have been told I have to have parathyroid surgery. Your breast cancer issue is recent enough where you could have had hyperparathyroidism that could be related, but I couldn't tell you. Hopefully you'll find a good surgeon to do a very good parathyroid surgery for you. Erin Wary, I had a surgery in December. The surgeon didn't remove a parathyroid gland because it's close to the nerve and embedded in remnant thyroid prior surgery. My calcium pH are still high. Can it be removed safely? Erin, hard to answer because I don't know how much scarring you have in there. Potentially, potentially a surgeon that's more experienced may be able to do it for you. It just would be hard to know without looking at what's in there. The other thing you have to check is how bad are your symptoms? How much are they affecting you? This is going to be a hard one to listen to, but here we go. How bad are your symptoms? How much is this affecting you? How much osteoporosis you have on one side? The downside of the surgery is obviously vocal cord paralysis. Vocal cords, let me show you, function like this. Okay, so these are the vocal cords, right? When you speak, the vocal cords come together and you say E, and when you breathe, they open up and the air goes into your breathing tube, right? When you have a vocal cord paralysis, only one side moves and the other doesn't. Now, if the vocal cord that's paralyzed is paralyzed in this side position, then you're going to have a breathy voice because the air leaks out, right? If the vocal cord gets paralyzed in the middle position, you'll have a normal speaking voice. So half the people who have vocal cord paralysis don't know it because their voice is normal. They only feel like, I can't scream as loud, but not a big deal, right? Singers would know it because singers do more functionality with their voice. In people who have vocal cord paralysis, what we do to treat it is we inject, the stuff that people inject in their face, fillers to make their face look more plump and take lines away. We inject it into the side here. That fattens up the vocal cord and makes their voice speaking voice go back to normal. I'm saying all this for you to know the two things you're comparing. How bad is your hyperparathyroidism and how much is it affecting you? How bad is the risk of getting a vocal? So if you're a doctor like me who can sound normal or sound hoarse and it doesn't impair your job so much, then having a vocal cord paralysis may not be as big an issue. But if you're a teacher, a public speaker, a performer, singer, judge, actor, whatever, someone who's speaking and their voice matters, right? The quality, what they're trying to convey and how they convey it matters a lot, then that vocal cord injury is maybe more of a priority than the parathyroid. And that's what you have to do. You have to try to prioritize and see what is the priority. Because a single-sided vocal cord paralysis can be improved upon so that your voice quality can be close to normal. It's a very hard decision to make, but that's where you sit. Good, best of luck, my dear. All right. All right, guys. Unfortunately, I have to get off. It's been 2 hours, almost, hour and 50 minutes. It's a joy being able to do this and help all of you, near and far. Hopefully, I've been helpful. Have a wonderful, wonderful day. We'll do this again in a month. Fonzie, I'm proud of you for persisting, and you're awesome. And thank you for sharing it with me and making my day. All of you, best wishes. Have a wonderful day. Bye.